All right. So we've talked about the underpinnings, touched on some of the underlying causes. That's a big whole day in itself to go over all that. But let's talk about gas and bloating. So hydrogen, methane, and hydrogen sulfide are the three main gases that we know are produced by bacteria and archaea. And so flora produce hydrogen and methane and some hydrogen sulfide. And then we as humans can also make hydrogen sulfide directly, but we don't make those other gases. So that's why when we do a breath test and we measure the amount of hydrogen and methane produced after drinking an undigestible sugar that the bacteria and archaea can digest and use to make gas, we can find out if they're overgrown or not. And excess gas tends to cause distension and bloating. It causes pain in some of our patients' clients, cramping, pain, and either movement upward, belching, or downward of gas. Patients that can't pass gas, either through belching or flatulence, tend to have much worse bloating and much worse pain because there's more pressure, parts per million of gas, that isn't being removed. Now, some of it gets absorbed into the blood and gets exhaled through the lungs, and that's why we can measure it in a breath test. So if you can't belch or pass gas through the rectum, you better hope that a lot of it gets absorbed into your blood so it doesn't cause so much pain that you're in the emergency room all the time. But that'll cause systemic symptoms, so it's a trade-off. And then there's altered motility, because gases also alter motility. This is a little graphic that comes from Dr. Elaine Gottschall's book, Breaking the Vicious Cycle, showing excess gas in the GI tract in SIBO, and just to give you a sense of how much gas excess there may be. So if we use the example of the amount of lactose contained in 1 ounce of milk, one little shot glass of milk, if someone doesn't have bacterial overgrowth and they drink that, they'll produce about 50 milliliters of gas if the lactose is not absorbed. So if they had lactose intolerance but they didn't have SIBO, if they have SIBO, the lactose in that 1 ounce shot glass, 1 ounce is how many mils? I went from ounces to mils, it's kind of a mixed bag there. But anyway, that could produce up to 5,000 milliliters of gas, 100 times more. That's a lot. And just as a visual, if we look at 1 ounce of milk creating, you wouldn't be able to see 50 milliliters in that big bottle unless it was white, so we put milk in there. So you could see how much gas would be produced from the lactose in that milk if the patient did not have SIBO. If they do, now we didn't fill them up, we didn't have that much milk, but 5 liters or 5,000 milliliters of gas from 1 ounce of milk, same amount of lactose. So you can imagine how much bloating, distension, possibly pain, and because it affects motility, depending on the gas, constipation or diarrhea as well. So fermentable foods are other sources, not just milk, not just lactose, but other fermentable foods are sources of gas for these bacteria to make more gas. And the small intestine and large intestine are sensitive to pressure, to distension. And that's what happens when you have that much gas in there. Also, sometimes there's this concept of visceral hypersensitivity in which the GI tract reacts in ways that are super sensitive to distension. Sometimes, we talk about the fact that normal peristalsis feels like pain to people who have altered visceral hypersensitivity. And so sometimes the muscles of the smooth muscle of the GI tract will contract around the gas and makes it twice as bad, right? So not only is it distended, but then it's contracting, which makes the amount of distension even worse. And studies of balloon inflation can reproduce patients' abdominal pain, meaning putting a balloon in the rectum and creating distension with air in the balloon. Methane tends to cause constipation. Almost every case, if there's hydrogen and methane, if there's some methane in there, there's going to be some degree of constipation. Constipation has a big definition. It can mean, you have to ask your client or patient what they mean by constipation. You can show them the Bristol stool chart and have them show you what it looks like. And then you can also ask them how often and whether it feels complete when they're done. But methane tends to cause constipation. It slows down the migrating motor complex. And I think it slows down flow through the bile ducts as well, because I've had patients with biliary dyskinesia that were scheduled for surgery, and we treated their methane SIBO, and the pain went away, so they canceled the surgery like 4 times and finally didn't schedule it again. I really like treating biliary dyskinesia because it's tough to treat, but I like it. Anyway, I think it causes reverse hypermotility in some of our patients. So reverse motility and more intense. So it's not just constipation, it's almost, well, if you think about reflux, gastroesophageal reflux, and bile reflux from the duodenum into the stomach, all of that, we see much more of that when there's this much pressure of gas and when there's methane. Even more so because I think it creates some reverse peristalsis, as well as slowing down the flow toward the anus. When they infuse methane gas into the small intestine of mice, they find a 69% slowing of the transit time. That's Dr. Pimentel and his group again. Hydrogen tends to cause diarrhea. Now, again, there can be a mix of archaea producing methane and bacteria producing hydrogen. And methane, of course, is made from hydrogen. So first, the bacteria make the hydrogen. If there's an excess, the archaea can convert that to methane. So you can have both. And that's why some patients with irritable bowel syndrome, SIBO, have alternating diarrhea and constipation. Or they have this weird kind of diarrhea that's Bristol 5 or 6, which is unformed stool, but it never feels complete. They'll have maybe frequent bowel movements, but it never feels done. Or they'll have that unformed stool, but it only occurs every 3rd day. So these interesting mixes of diarrhea and constipation you'll see in these patients. But the degree of diarrhea usually is related to the quantity of hydrogen-producing bacteria. Of course, you never get a single hydrogen molecule. I'm not sure why there's no 2 there. I'm sorry about that. And they've also found that fibromyalgia is associated with hydrogen SIBO. And the higher the hydrogen level, the more fibromyalgia pain. Another light bulb. Constipation and diarrhea are symptoms of SIBO, not the causes. It's not the constipation that slowed things down. Constipation is large part happening in the large bowel. Here we're talking about the whole preliminary setup in the small bowel. How do you test? So the small intestine is a difficult place to test. Upper endoscopy only gets to generally the second, maybe the third or fourth portion of the duodenum, so the very first centimeters of the small bowel. And the small bowel is, they say, 18 to 20 feet long. A colonoscopy only gets to the last few centimeters of the terminal ileum, the very end of the 18 to 20 feet. So there are some new techniques where they can go through, traverse the entire small intestine, but they are very unusual, and they're only done in certain motility centers in the US, very few. And it's not used very often. So there's no perfect test to actually get a sample. You can get a sample with upper endoscopy from the duodenum, the very beginning. But we see a lot of cases where it's overgrowth somewhere in the middle of the jejunum or down closer to the terminal ileum. So we don't want to miss those. The culture of the duodenal aspirate, therefore, is not a valid gold standard, although it's often called a gold standard. It's really only showing proximal SIBO, the most proximal type of SIBO, right up in the upper duodenum. Also, a lot of hospitals don't actually have the right techniques for doing getting a sterile culture. So you really have to get somebody who knows what they're doing. Lactulose breath test. If you look at lactulose versus glucose, you can use either substrate. The patient first exhales into the collection device. You get a baseline while they're fasting. Then they drink either lactulose or glucose as a substrate. The bacteria or archaea will then convert that into gas. And they're going to exhale every 20 minutes, and then we're going to measure the hydrogen and methane over 3 hours to see how much bacterial overgrowth or archaeal overgrowth there is. When you look at the stats, the sensitivity and the specificity of lactulose versus glucose, glucose looks much better. The reason it looks much better is they're comparing it to the gold standard, the duodenal culture, which is only measuring the very proximal overgrowth. So glucose is absorbed in the first 2 feet of small intestine. It doesn't show you what's going on after the first 2 feet. So it looks really close to what you see with the gold standard. But as we said, it's not really a gold standard. It's not a valid gold standard because it's only showing one type of SIBO, the proximal type. Lactulose is unabsorbable by humans. So, is that a word? Unabsorbable or inabsorbable? And it goes through the entire small bowel and the colon. You can actually see where it traverses into the colon because the levels of hydrogen or methane will go way up, especially hydrogen, because you expect to have trillions of bacteria in the large intestine. So this way, with lactulose, it doesn't look as good in terms of sensitivity and specificity, but that's because it's being compared to a non-valid gold standard. We like to look at the whole thing, so we use lactulose most of the time, occasionally glucose. Another light bulb. Stool culture has no relationship to small intestinal flora. A breath test or duodenal aspirate is necessary. So please don't think you can diagnose this from a stool culture. That'll tell you if there's overgrowth and what kinds of bugs might be present in the colon, especially the left side of the colon, we think. There are other kinds of breath tests, so don't be confused. There's a H. pylori breath test, a urease breath test. There's the testing for sugar intolerance, lactose intolerance, sorbitol intolerance, fructose intolerance. And then there's the SIBO breath test, which could be lactulose or glucose. And like I said, your patient or client, when they drink this solution, the bacteria make gas. We can only measure hydrogen or methane. They're working. They've been working for 15 years on making a machine that will check for hydrogen sulfide, but it's still not commercially available. So we only measure those two and graph their levels over 2 to 3 hours. The patient does a 1 to 2 day non-carbohydrate diet, just no carbohydrate at all, so that we're not feeding the bacteria, giving them any substrate for 1 to 2 days prior. And then they come in fasting in the morning and we do the breath test. We want to get a nice low baseline if possible. Then we can see how much rise there is or not. And there are different definitions of what is a positive test. There is I think there was an international group that got together to put together the first suggestions for normal ranges. But the maker of the machinery, the Quintron breath tracker, their normal ranges, I'm going to show you those. So for a lactulose breath test, a hydrogen 20 parts per million or greater, especially if you want to measure in the first 120 minutes the lowest level that it was at all during that time and the highest. If there's a 20 part per million rise or more, that's a positive test. Some doctors really like to use just the first 90 minutes and they don't look at the rest. The maker of the machine says 120 minutes. It's thought that lactulose takes about 105 minutes to traverse the small intestine, and it takes the bugs about 15 minutes to make the gas. So that gives us 120 minutes. And personally, I think that not everybody has the same transit time. I mean, we know that when we do transit studies, some people have much longer transits. So that's an average. Like Dr. Bland talked about this morning, individual rather than part of the herd. Methane, 10 parts per million or greater, from the lowest to the highest. Or really, at this case, we don't really use it. We just use it at the actual level, 10 parts per million or higher, at any time during the test. Because, raise your hand if you think all human beings have hydrogen-producing bacteria in their guts. Everybody raise your hand. You're right. We would be dead without them, right? We all have those. But not everybody has methanogens. Not everybody has the specific archaea that can convert hydrogen to methane. So it's a lower amount. And you'll find a lot of people that have no methane at all or very, very low levels, but hydrogen is more their problem. If you're looking at combined gases, both hydrogen and methane, in the first 120 minutes, it should say in the first 120 minutes, 15 parts per million or more of a rise from the lowest to the highest level in that first 120 minutes is a positive, if they have both gases. On a glucose breath test, it's 12 parts per million over the lowest preceding level and over the first 120 minutes or 90 minutes if you like the shorter time. There's also something, it says at the top, not SIBO, but a useful diagnosis. Methane, because it causes constipation, they've found when they've measured parts per billion instead of parts per million of methane, that it really is when you use a more sensitive marker, they've found that any methane level greater than 2 parts per million can cause constipation. So we just call that methane-induced constipation. And we may treat those patients to bring down their methane levels. But it's not SIBO. Okay, let's talk about treatment. And I have whole breakout sessions on looking at breath testing, and here's the way it looks in this syndrome, and here's the way it looks in this syndrome, and this is positive and this isn't. We don't have time for that today. I just want to give you an overview. So our goals for treatment. We want to treat the underlying cause whenever possible. There are some underlying causes we can't treat, such as superior mesenteric artery syndrome, SMAS. It's not very common, but because I see complicated cases, I see more of them. And these are people who have pressure from the superior mesenteric artery against the duodenum, so they get a partial compression, partial obstruction that's near permanent of their duodenum, which slows everything down and causes a bacterial overgrowth. So that's not one that I really have a treatment for yet. But, I mean, there is surgical treatment, but that leads to adhesions, and that doesn't tend to help. So in general, you want to reduce the number of bacteria and or archaea. You want to detoxify and support brush border healing and prevent relapse. The prevention phase is very important. Even if you've treated the underlying cause, it's very important. And a lot of doctors, they don't even know about that. They just treat periodically. And that's better, I guess, than not treating, depending on what your treatment is. So consider the following. Diet. These are the diets that I use most commonly. Specific carbohydrate diet, the SIBO food guide that Dr. Siebecker put together from the specific carbohydrate and the low FODMAPs. She put them together into one chart for the patient, and way easier to follow than two different diets. Here's my general suggestion. Never give a patient two different diets to follow at the same time. It makes them crazy. So Dr. Siebecker put the two together in one chart and one handout. And you can find that at her website, siboinfo.com. It's there for free for anybody to access. Then there's the pure low FODMAPs diet from Monash University in Australia, and there's the Cedars-Sinai diet, a low fermentation diet from Cedars-Sinai, Dr. Pimentel in Los Angeles. There's also a newer one that a student of Dr. Siebecker and myself put together, who's been in practice now for 10 or 12 years in Australia, Dr. Nirala Jacobi, and she calls it the biphasic diet. It's basically Dr. Siebecker's SIBO food guide with some modifications. And if you have a patient who's vegan or vegetarian, it's more friendly for them. Here's some general things I'll tell you about vegetarians and vegans in terms of these diets. This first diet, specific carbohydrate diet, don't do it. Unless they're an omnivore, they will lose way too much weight. Most of my patients, the majority of patients with this problem are underweight. There are some people overweight, but we tend to see the underweight ones more. So if they are a vegan or a vegetarian, don't use SIBO food guide. That's not going to work. Use either low FODMAPs, Cedars-Sinai, or the biphasic diet. I've been in practice 41 years. I've made every mistake you can make. I'm telling you from experience. There's also, besides diet, now our experience is diet relieves symptoms by not giving the bugs fermentable carbohydrates to make gas. So it reduces gas. For some people, it's all they need. It relieves 100% of their symptoms. But it doesn't get rid of the overgrowth in our experience. Elemental diet, using truly elemental powders where there's nothing to digest. It's all elemental nutrients. For 2 to 3 weeks is an excellent treatment for bacterial overgrowth, assuming you've already addressed the underlying cause, so it won't just come back. And prescription antibiotics are also used, and botanical antibiotics. This is the newer version of our SIBO treatment protocol. It gives the patient, client, and the doctor an idea about the stages of treatment. So you don't just think, oh, take this herb, take this antibiotic, you're done. So if they have a positive SIBO breath test, they have options for treatment, three options plus diet. We tend to always use diet along with it. So either prescription antibiotics, elemental diet, pre-digested elemental nutrients, or herbal antibiotics. And then everything leads to a prokinetic. Prokinetics are herbs or prescriptions that move things through the stomach and the small intestine, just like the migrating motor complex. Some prokinetics actually move the colon as well, and so we'll tend to prefer those for patients who are really the worst kind of constipation, because it can help with that too, to produce a bowel movement. If they feel 80 to 90% better after the treatment, then we just go into prevention mode with diet and a continued prokinetic, depending on whether or not they have those antibodies that we talked about before, the anti-CDT and the anti-vinculin. If they have high levels of those, which you can measure in the blood, I tell my patients, besides the diet, you'll really need to do prokinetic therapy for at least 3 to 5 years. Every night, they just take that. And it could be something as simple as ginger, which is an excellent prokinetic, but we have a lot of choices. But it's very important, because if you don't maximize that migrating motor complex, their risk of relapse is going to be much higher. And so we have relapse down at the bottom with a dotted line. It doesn't have to happen, but if it does, further investigate underlying causes and deal with whatever you can, and then treat them again if they still have a positive breath test. Just wanted to, for a change of pace, this is my GI mentor rotation students from last year, and my resident physician. That's all of us. We see patients in Portland, Oregon. Student doctors get to see complex GI cases with supervision from me and my resident. All right, so let's talk about prescription medicine. Rifaximin, Xifaxan is the brand name, Rifaximin is the generic. This is a medicine that is unique because 99.6% of it stays in the gut. It's what we call a luminal agent. It's not absorbed, or very little. And because it's exclusively a luminal agent, it's especially useful for treating, reducing bacteria in the gut. So it's in the U.S., it's FDA approved for traveler's diarrhea, small intestine bacterial overgrowth, no, but IBS, yes, and hepatic encephalopathy. Does that one kind of stick out like a sore thumb? Hepatic encephalopathy? Does everyone remember the simple test for hepatic encephalopathy? If you have a patient with chronic liver disease, cirrhosis, and their liver's starting to fail, and their levels of ammonia are escalating, That's very toxic to the central nervous system and to the peripheral nervous system to some degree. So here's what you do. Try it right now. Just extend your arm straight out in front of you if there's not somebody right real close. And then fully extend your wrists towards your head. And I'm not seeing anybody with a flapping tremor from here, but if you have hepatic encephalopathy, you can't keep your hands in extension, your wrists in extension. They'll flap like that. It's called asterixis, or flapping tremor, and it's a strong sign of more advanced hepatic encephalopathy, toxicity to the brain from ammonia being produced by bacteria breaking down nitrogen in the gut. So, interesting thing, this is one of the best treatments. These patients, they actually have $500 off coupons for Rifaximin for these people because they have to use Rifaximin pretty much all the time, like just daily, a lot of these people, because they have so much overgrowth and it causes them to go crazy and to have all kinds of encephalopathy. So it's used for that. Rifaximin comes in two strengths. It's manufactured by Salix. There are generics as well from India and from Italy. It's very expensive in the US. Without insurance coverage, it could be $1,200 to $2,000 US dollars for a 2-week course. But a lot of insurances cover it. And some people get the generic from India, which is much cheaper, and I don't know if that's a good idea or not, but some doctors prescribe that. So Rifaximin dosage for patients with IBS-D, you can use Rifaximin by itself. It works very well for hydrogen-producing bacteria. And the preferred dosage is 550 milligrams 3 times a day for 14 days. And LBT, lactulose breath test, GBT, glucose breath test, that's a success rate for normalizing the test. For IBS-C, constipation type, methane of any amount, if the patient's constipated, or if you're just treating methane and they don't have a hydrogen overgrowth, you're going to have to use a second antibiotic. This is where it starts to get, I don't like it as much when I have to do this. So it's nice when the patient wants to do herbal treatment or something else. But this is very effective for a lot of patients. So there'll be a combination of the Rifaximin plus either metronidazole or Rifaximin plus Neomycin. Neomycin is another poorly absorbed antibiotic, so it works similarly to Rifaximin. So you can't treat methane SIBO if you're using prescription medicine with just one antibiotic. Unfortunately, it takes 2. So there's a kind of a repeat on one slide of the dosages. Herbal antibiotics. Now, there was only one study that's published comparing herbal antibiotics to Rifaximin and other prescription antibiotics at Johns Hopkins University. And they found that the herbal antibiotics were about 12% more effective at normalizing the breath test. They didn't look at symptom improvement. They didn't look at methane. They only looked at hydrogen gas and normalization of the test. I think they did that because it looked better if they just narrowed it down to that. But nice to know if your patient or client says, I want to do the most effective, the fastest, the best thing. What should I do? Herbs or prescription? Statistically, they were the same in this study. And if you look at the details, a little bit better if you use the herbs. Nice thing about herbs, of course, the herbs that we use don't cause yeast overgrowth, but the antibiotics can. So if you have someone who already has yeast overgrowth or is very prone to it, you may have to do something to help reduce yeast while you're using 2 antibiotics. But you don't need to with the herbs. So we tend to use, for hydrogen, we tend to use herbs that contain berberine, such as golden seal or Oregon grape, philodendron. And we use a big dose, 5,000 milligrams a day. Usually in divided dosages, it's 1,500 per meal, plus an extra 500 at one of those meals. Optionally, we might add neem, Asdaraachta. Sometimes we also add neem plus what we call trifol, which are 3 Ayurvedic herbs that help with mucosal health. And if you really want to beef it up, you can add oregano. And oregano can be used by itself as well. What we see is an average reduction of gas of 25 to 35 parts per million in a month course of herbal treatment. And that's pretty similar to what we would see with prescription antibiotics for 2 weeks. So it takes twice as long, but I like it a lot. So here's the Johns Hopkins information again. Study by Chadid. So prokinetic options after the herbal treatment or the prescription treatment. We'll start with prescription prokinetics. So erythromycin, you would recognize as an old antibiotic that really isn't used much anymore. Zithromycin is the new erythromycin. And we generally use some kind of prokinetic for at least 90 days after the treatment phase. And like I said, maybe 3 to 5 years or longer for patients that have tested high for antibodies. Erythromycin, though, all you need is 50 milligrams. The dosage that used to be used as an antibiotic for pneumonia and other things was 750 milligrams a day up to 1,500 milligrams a day. So this is a very small dose. It's not an antibiotic dose. It's subtherapeutic for that. But it's a motilin agonist. Remember I said motilin is one of the major neuropeptides for the migrating motor complex. So it's really helpful for that. It's a great treatment for gastroparesis as well. That's probably what I would choose if my patient has diarrhea tendencies, hydrogen SIBO, IBS-D, and I don't want to stimulate bowel movements. If, on the other hand, I'm choosing a prokinetic that's prescription for a patient who has really severe constipation after we've treated their methane, I often use prucalopride, which is the generic. Resolor in Canada is the brand name, or Resotran in Canada. And in the United States, it's called Motegrity. Kind of a cool name, Motegrity. That just got FDA approved about 2 months ago. It's, in my experience, that and erythromycin are definitely the safest prescription prokinetics. But this one, prucalopride, is also a 5-HT4 agonist. So it works on serotonin receptors, which then helps move things through the colon. Can be a really, really effective laxative for these people, as well as a prokinetic at very low doses. We usually give them the 2 milligram tablets, and they cut it with a pill cutter into 4 parts and take a quarter of one or a half a milligram. For my patients who do have those high levels of antibodies or some other known autoimmune disease, I really like to offer them low-dose naltrexone, which I'm sure everybody knows about that. It's an excellent low-dose endorphin receptor blocker that helps actually increase endorphin levels. Endorphins are really important, of course, for downregulating inflammation and autoimmunity. So we talked about herbal treatment for hydrogen, herbal treatment for methane. The best that we have found is allicin extract. Now, if you know anything about low FODMAPs diet, the highest vegetable FODMAP containing vegetable is probably garlic. So this will blow up a lot of your patients if you give it to them as a medicine, as whole garlic. So unfortunately, here we have to use an extract and just take out the allicin, which is the antifungal, antibacterial element in garlic, and not give them the fructans that would be present in the whole clove. You don't want those sugars for most of these people. Dr. Jacoby did a little unpublished study, found that could drop the methane by up to 50 parts per million in 30 days. And at our center, we had one that was 41 parts per million in 30 days. That's better than you should expect. That's just our Guinness Book of World Records. By the way, I had a patient several years ago who had a methane of 104 parts per million. As you recall, anything over 10 is high. She chose to take metronidazole and rifaximin and for 2 weeks, and we repeated her test after that, and her level was 4 parts per million. So it dropped it by 100. That's my Guinness Book of World Record biggest drop in methane with prescription. So oregano is also a good choice. Oregano seems to be effective both in methane and in hydrogen SIBO. We tend to use an emulsified oregano, 50 milligrams 3 times a day. Of course, if your client or patient is hypochlorhydric, you're going to have to deal with that, however you want to do that. Just some simple things here. I like to check the lower gate or the ileocecal valve using applied kinesiology testing. And I use, in quotes, closed or open. If you've done anything with ileocecal valve syndrome, I mentioned that we want to keep it closed when it's supposed to be closed, open when it's supposed to open, and then close right away. So some people test for sort of a closed valve, meaning they have hypertonicity. The valve doesn't open very well. And other people test for an open valve where it doesn't close very well. And I've seen this when I read colonoscopy reports. I've seen it say, for an open valve, it'll say, clear bilious fluid was seen emanating from the ileocecal valve as they're coming into the cecum. Or the ileocecal valve was open. That's a direct quote from a colonoscopy report. So sometimes you'll diagnose this by reading colonoscopy report. I highly suggest don't take anybody's word for it was a normal colonoscopy. No, send for the report and the biopsies and read them yourself. If you don't know how to read them, it's a great thing to learn how to read them and really make sense out of them. And a closed ileocecal valve, you may have heard of people who've had colonoscopies. They were trying to get through into the terminal ileum, but they couldn't. They couldn't get through the valve. It just wouldn't open. And then they'll have to do some kind of a small bowel follow-through barium or MRI enterography to actually look at the small intestine because they weren't able to get in there with the scope. That's a closed ileocecal valve. But you can use applied kinesiology testing to just check in your office for a functional open or closed valve. The way I treat that, there are different visceral techniques that we use in the right lower quadrant, working the soft tissue. Also, I wrote a textbook on functional gastroenterology, and there is a whole chapter on ileocecal valve, so if you want more information, you can look at that. But C5 and L1, cervical 5 and lumbar 1, are the most important areas to check if your patient has an open ileocecal valve. For muscle work, for fascial work, for spinal work, whatever you find there. But check those areas. And if they have what we call a closed ileocecal valve, C3 and L3 are the most important places to check. And then, of course, you're working with their diet and their supplements. There's a lot of detail to this, but anybody know what the worst food, thought to be the worst food for the ileocecal valve is? Popcorn, yeah. There's this graphic quote that popcorn is like razor blades going through the ileocecal valve. You know the little seed, the brown seed coat in the middle that, it's all puffed up, it all dissolves in your saliva, it's gone. You put it in your mouth, the popcorn's gone, but that seed coat never digests. And it goes all the way down and is thought to be very irritating. So popcorn's one of the foods that we tend to have people avoid. Enzyme replacement, or any way that you can get the enzymes to increase in amounts. I tend to use the plant-based enzymes before meals because they can work in the stomach at any pH from 2 to 12, they say. Tend to use pancreatin or pork-based, animal-based enzymes after meals because they work in a more alkaline pH. We use brush border enzymes if we're going to use those with meals. And papain or bromelain, which have all kinds of good digestive effects with meals as well. And if your patient has any issue with their bile flow, you want to consider that as well. Part of the upper gate. So prevention phase, again, for methane, prokinetic options for at least 90 days, sometimes longer. Listed them again. And there's ginger as an herbal prokinetic. There were a few more, but they were proprietary, so we removed them. But I can just explain the basic idea. Some nutraceutical company decided they were going to look at all the research on natural products that might help with motility for the large bowel and the small bowel. And they made a combination of ginger for the upper gut, 5-HTP and P5P for the serotonin receptors in the large gut, and acetylcarnitine as a precursor to acetylcholine. Sometimes we use that, and it also had the ginger, like I said. Some doctors like to use D-limonene. I think that's one of the favored ones of the Johns Hopkins group, and they tend to use 1,000 milligrams, also at bedtime, QHS. It's funny, though, D-limonene is purported to be a great treatment for gastritis and esophagitis and reflux. And for some reason lately, maybe I got a bad batch or something, but lately it seems like it's causing more burning in those people instead of relieving their burning. So I got to look into that a little further. There's also a German liquid herbal formula that has over 100 studies in PubMed that I won't mention the name of, but it's a liquid herbal that contains the lead herb Iberis, Amara. So treat the underlying cause or mitigate it as much as you can if it's not curable. There again is the colorful copy of our treatment protocol. Take a look at that again later. And if you want more information, more detail, on any of these things. In my second edition of my textbook, Chapter 6, I'm not sure what that S is. That just got in there stray. Chapter 6 is on SIBO. Chapter 10 is on the various diets, more details on the diets I was talking about. Chapter 11 is on homeopathics for GI, bloating, and other symptoms. Chapter 13 on gastric secretion and hypochlorhydria, achlorhydria. Chapter 14 on pancreatic insufficiency, and 15 on ileocecal valve syndrome. And I bet that's the last slide. So thank you for your attention.